We have a very interesting program on respiratory care in ALS, and I think that's one of the primary areas that a lot of people have questions about. And we're in a time when we really have to be proactive and partners with our medical, our care professionals. And so this is where the focus is going to be today. We're going to be hearing from Dr. Andrea Anton, and then this morning, Dr. Barkhouse will do her official introduction. And then we'll be joined by Marmalette Shepker and Ellen Newman, who are respiratory therapists from the Fredert ALS Clinic and the VA, respectively. So I will have Dr. Barkhouse introduce Dr. Anton.
Yes, as Lori said, respiratory function is very, very critical, not just in a reactive way, but in a planned, proactive way. So our staff at Fredert in the pulmonary division is very active, and then when we became more active in the VA over the years, we were fortunate to have the young lady to my, now that's my left, at the right side, correct side, I mean. And Dr. Antonescu was a very willing participant and enthusiastic. She even comes down to clinic on occasion to save the vets a trip to make a brief assessment if needed. So she's kindly agreed to speak to us about respiratory function, and she's also interested in pursuing some clinical research activities with us, which we welcome. And of course, I have to make this a very flowery introduction because she's technically my, well, not technically, she is my boss at the VA. I have one neurologist over me, and then it's her. So anyhow, I'm used to my life being ruled by women, starting with my mother. Anyhow, so without further ado, Dr. Antonescu.
Thank you. Thank you for the great introduction. Dr. Barkhouse keeps calling me Dr. Antonescu. I'm Romanian, and I had a very long Romanian hyphenated last name. And just recently, I became an American citizen after 16 years, and I decided to shorten my name. So if you see Antonescu and it's Anton, it's still me. I try to escape so nobody can track me down. First of all, I would like to thank Dr. Barkhouse and Lori for inviting me to this wonderful event and to be able to talk to you about the respiratory involvement in patients with ALS. Then I would like to thank Marlette and Ellen for helping me taking care of my patients with ALS. I could not do it without them, so thank you. And then I have a couple of disclaimers. This is the first time I'm attending this event. This is wonderful. I'm very excited, and I'm already looking forward for the next year event. So I know it's a lot of hard work going behind the scene, and this is just great. And then last but not least, I want to thank you, my patients with ALS, to your families and caregivers. It is truly my pleasure and honor to take care of you. You have a special place in my heart, and even I have a big administrative job that keeps me busy during the day. Coming down to clinic and taking care of you and be part of your journey, it's a blessing. So thank you. And I'm following two great speakers, and my talk has a different focus. I think it's simpler in some ways, but probably more relevant to what you're going to experience when you come to see us, when you have problems breathing. So when I was putting the talk together, I was thinking, how should I do it? Should I share with you some of the publications that we have, the limited data that we have? And then I thought, well, how would that help you? I think, it's in the afternoon when we all get sleepy. I'm following the lunch, so I'm sure half of you will be probably asleep by the time I'm done. So I said, well, I'm just going to do what I do in clinic. How do I approach my clinic visit? How I talk to my patients about their symptoms, what's out there for them, and how can I help them? How can I be part of your journey when you deal with ALS? So that's what I do. I start talking about the different group of muscles and how they are involved in respiration, and how do they get involved when the patients have ALS. And then we talk, okay, well, we have the disease, we don't have a cure, but I'm there to help you. and what are the means of helping you, and when and how we should think about helping the patients who have problems breathing. And then it's not just the breathing, it's also the cough that it's a big challenge for you. And then I'll briefly talk about diaphragmatic pacing and where we are with that. And last but not least, when to consider mechanical ventilation and how do we approach that. So I'm going to start with the respiratory muscles and ALS. So very simplified, what is the role of breathing? Well, it's to get rid of the carbon dioxide and enrich the blood with oxygen. So in order to achieve that, we need our breathing muscles, and we have main inspiratory muscles. The main breathing muscle is the diaphragm. We have the muscle of the upper airway. They keep the upper air open. And then you also need your chest wall muscles that all coordinate the breathing. And then we need the cough. And we need the cough to protect against secretion buildup and prevent aspirations and pneumonia. So if we, do I have a pointer or the mouse that can work?
Oh, the mouse.
Yeah. Well, I'll just talk without pointing. So on the left side, okay, that's fine, thank you. So on the left side, we have the muscles of inspiration. So the diaphragm is the main breathing muscles, and when the diaphragm contracts, it moves down, so that creates negative pressure, so air gets sucked into the lungs. And also we have the intercostal muscles, which what they do that pull the ribs outward and upwards. And then if the muscles need more help, you have what we call the accessory muscles or the neck muscles that will further elevate the upper ribs, so our chest wall will move all directions, downward, outwards, and upwards. And that's how we can pull more air in. Expiration, on the other hand, we don't need as much effort. So if it's normal breathing, it's passive. Everything, we're just going to go back to rest. But if we have to augment the expiration, we have the intercostal muscles that we're going to squeeze the ribs inwards, and the air will going to be flowing out. So based on what kind of group of muscles are involved, I'm not a neurologist. I'm not going to talk about upper motor neuron and lower motor neuron. I'm going to keep it simple. What group of muscles and what happens? So if you have respiratory muscle involvement, you cannot pull the air in. So the breathing becomes shallower and faster. And as a result, the oxygen level drops, the carbon dioxide level goes up, and then cough, we'll spend a little bit more time on cough, but cough, it's a very complex process that needs all muscles, the upper airway, the inspiratory muscle, the expiratory muscle. So if any of those muscles are involved, the cough is pretty weak. Expiratory muscles, as I said, if they are involved, the cough is poor. And then the upper airway muscles, which a lot of patients with bulbar involvement experience, we're going to have, besides the poor cough, they're going to have problems handling secretions, and they are at risk of aspiration and aspiration pneumonia. So how do we know when the muscles are getting involved? Well, we're going to start slowly, but you'd see that the activities of daily living become harder to be accomplished. As you lay flat, you're going to lose the advantage of gravity. So the diaphragm will going to become floppier, and will be, as we lay flat, the abdominal content was going to be moving up, and the lungs could not expand, so it would be hard to breathe if you lay flat. And then sleep, it's a very vulnerable part of the day because the muscles were going to become weaker. So if they don't have problems, if you do not have problems during the day, the patients may experience problems at night. So they were going to wake up in the morning feeling unrefreshed. They were going to have headaches in the morning, and that's a result of carbon dioxide accumulation. They will have cerebral-related chokes, and then problems with phlegm clearing. A little bit more on the diaphragm weakness. As I mentioned, it's the main muscle of inspiration. So when the diaphragm starts failing, the accessory muscles are used. So when I see the patients in clinic, just looking at them, I can see if the neck muscles are engaged. And you would see a lot of neck muscles involvement, and they are pretty tense as the patient is just breathing normally sitting in a chair. So signs of diaphragmatic weakness include, initially, as I said, it starts when we need more, so exercise or work-related shortness of breath, and then progressively comes down to the activity of daily living, and ultimately just at rest. And again, patients are unable to lay flat. The upper airway muscle weakness, it comes in a package. The patients who have bulbar involvement, they would have problems swallowing, choking, dysarthria. The speech is pretty altered, and hoarseness. And if the upper airway muscles become too floppy, they can, during sleep, they can collapse. So the patient develop obstructive sleep apnea, but they also can develop central sleep apnea where the brain does not tell you to breathe. But that would be a different story. If we do an X-ray, on the left-hand side, it's a normal X-ray. So you can see that the lungs are nice and tall, and black is air. So black means that there is air inside the lungs. And when patients have ALS, the lungs are not as tall, so the lung volumes are small, and the bottom part of the lungs do not expand. So they become collapsed like pancakes, right at where my arrows are. And those are areas that, the air is not going in and out. And you could imagine that as you lay down, those bottom parts of the lungs, they are not expanding, are becoming even bigger, and that's why patients are short of breath when they lay flat. So we think that patients may have respiratory muscle weakness. And sometimes it's very hard because the patients may not describe they are getting short of breath because they are getting weaker otherwise. So they are not doing as much. So it's really, is it the weakness that's getting worse? Is it the muscle, the breathing muscle they're getting worse? It's hard to tease. So in order to make sure that we stay ahead of the game, we do some certain tests to look at the respiratory muscle strength. My disclaimer is that no single test is diagnostic, so we treat patients, not numbers. So we put I put the numbers in the context of treating the patient. And if the patients have bulbar involvement, you really do not have good predictors. So again, we do it, we use those numbers, and for that matters, we do need the numbers to prescribe therapy, but you have to use it in the context of each individual patient. And there are a lot of acronyms when it comes to pulmonary function tests. A lot of you, I'm sure you are familiar with MIP, MAP, FVC, SNP, whatever. We come up with different abbreviations, but the spirometry or the forced vital capacity is most commonly used. We do it in clinic. We do it every 3 months. We ask the patient to blow through a mouthpiece. The problem is if it's very hard for them to seal their mouth around that mouthpiece. You can get artificially low numbers, and it's hard to interpret. If you look at measuring the strength of the diaphragm, we say, well, just blow as hard as you can or take a deep breath as hard as you can against the occluded valve. So, you measure the pressure that you generated, and that's what maximum inspiratory and expiratory pressure means. And then the sniff, I have a couple of slides, is just you measure the pressure in the nose because especially in patients with bulbar involvement, it's hard to have their mouth sealing around the mouthpiece. Then one can say, well, if really you have hard time measuring all those pressures and they are inaccurate, well, why don't just measure the end result? If the breathing is meant to pick up oxygen and get rid of carbon dioxide, why don't you just measure that and do a blood gas? We do a stick in the wrist, in the artery, and we measure the level of oxygen and carbon dioxide. And if carbon dioxide is elevated and the oxygen is low, well, That's bad. And the problem with that, this is a late finding. So we missed the train. We should have been proactive and make sure that we are not going to wait until the patients fail to realize that they are failing. And maybe, and that's where the data is coming from, that if we start a little bit earlier, we can maybe alter the course of disease. And then, as I mentioned to you before, night is it's more susceptible. The patients are having more problems at night. So why don't you check the oxygen levels at night? Throughout the night, we have a little oxygen probe that's linked to the wrist, and you wear this as you go to bed, and you wear it for the duration of the night. And we look at the oxygen levels throughout the night and see what happens. And there are studies to suggest that when you identify the patients based on their oxygen levels at night and implementing therapy, it can make a difference. So we do that as well. This is just to show you how the vital capacity is done. There are studies suggest that if you lay on your back, so in supine position, again, you lose the mechanical advantage of the gravity. So that may be an early indicator of diaphragmatic weakness. But what we need to remember as physicians for prescribing purposes is 50%. If it's less than 50%, it qualifies for it's one of the Medicare criteria. And then, we need to talk to you, and hopefully we have talked to you before about assistance with breathing. This is how the sniff nasal inspiratory pressure, one nostril is occluded, the other one has a little probe, and we ask the patients to take a breath, and a number less than 40. It's what the studies have suggested that it correlates with low oxygen levels at night that need for assist with breathing. So this is the brief overview about respiratory muscles and ALS. We're going to move on and talk about, we know the muscles are weak. How can we help them? How can we charge the batteries for the breathing muscles so they can be more efficient during the day? I think the first point that I want to make is oxygen is not enough. Patients, is nothing wrong with the lungs. If the oxygen levels are low, is because the breathing muscles are weak. So they're not able to pull the lungs up, and just giving oxygen will not going to be enough. The other thing is for all of us to breathe, the brain either perceive the elevated carbon dioxide level or low oxygen levels. And that's how the brain tells us, take a deep breath, you need a breath, our carbon dioxide level is too high. As the muscle gets weak, the patients start building up CO2, and brain becomes used to high carbon dioxide levels. So only trigger for the brain to breathe is the low oxygen level. So you give oxygen in that situation, the patient stop breathing, and their carbon dioxide level will gonna keep going up. And it may be at some point in the disease that we'll have that conversation that, it's nothing, there are no other options, and giving oxygen for comfort level will help the patient, but that's not the main treatment. So I just wanted to make sure that comes across pretty clear. And then we talk about what really can help the breathing muscles. And I'm going to use the term of non-invasive ventilation. Probably you're used to the term BiPAP, or and different. We are used to the trade names rather than what they do. So for the purpose of my talk, I'm just going to use non-invasive ventilation, which means positive airway pressure therapy. So the machine is going to push the air in to help the patient take a bigger breath. That will gonna result in improved oxygen level, decrease the carbon dioxide, and really rest the muscle. So instead of muscle working to pull the air in and get it out, that machine will gonna help the effort. And what we know from the limited data that we have is that it does improve the quality of life. And for the patients who are able to tolerate it, they're gonna help them live longer. When to start? Well, we have a combination of numbers and symptoms. So it's important if we say, well, if you think that we're going to help, well, just give it from the very beginning. Well, I don't think we have the data yet. If you don't have respiratory symptoms, to suggest that if you don't have symptoms, just start PAP therapy. I also tell my patients that when you start the PAP therapy, it's really like riding a bike. You don't get it right the first time you do it, and more you do it, better you get at it. We are not born with a mask connected to a machine, so it's a big learning process. And if you don't have symptoms, it's probably the compliance with the therapy for those patients who are going to be pretty poor. So we have the symptoms, and the symptoms include having problems laying flat because of shortness of breath, morning headaches, and sleepiness. And then we have the pulmonary function test results, some of the tests that I mentioned a little bit earlier. And those are the numbers that have been approved by Medicare and our organization Consensus. So we have a forced vital capacity less than 50%, MIP less than 60, it's actually centimeter water, SNP less than 40, and then we have the blood gases. And those are the current Medicare guidelines. You could see that the indications on the left-hand side are the chronic neuromuscular disorder and thoracic cage disorder. This consensus conference took place in 1998. They came up with what I just mentioned before, the symptoms plus a combination of test results, whatever you have. And then Medicare really didn't make any changes when those guidelines were approved. I think one important part of this slide is sleep study is not needed to prescribe PAP therapy. Other criteria that we have to keep in mind is the patients are mentally competent and cooperative. Some of the patients who have ALS developed dementia, so for those who have it, it's not going to work, and it's just the reality. It's just it's really very hard for them to comprehend, and it's really a therapy that will not going to work for them. I did have a patient like that probably 3 weeks ago, and the wife was struggling. He's getting more short of breath, and he really can't express what he would want. And I said, okay, well, let's do an overnight oximeter. And he really didn't want to wear the overnight oximeter on his finger. And the wife was struggling with what can he do, and he also didn't want the non-invasive ventilation. So the question was, what about a tracheostomy and beyond mechanical ventilation? And I raised the point that if he really doesn't want something on his finger for the duration of the night, what are the chances that he would be comfortable with a hole in the neck and be connected to a ventilator? And I think those are, unfortunately, the discussion that we have to have, where we talk about how we treat the patients and how we help you. I am there to help you and have those discussions and make sure that we honor the patient's wishes. So the patient has to be mentally competent and cooperative. You have to should not have history of uncontrolled seizures. So, and then we have the face has to. We need to make sure that there are no big facial abnormalities that a mask would not stay on the face. But luckily, we have many interfaces available at this time, so I'm sure one of it will be able to help you. What are the settings? And this is mainly for some of the respiratory therapists who may be in the audience. The machines that we have are referred by the trade name, so we have BiPAP and VPAP. And I put some initial settings. I think, I not one size fits all. I think it's very important to have an experienced respiratory therapist who will work with the patient. I give my pressure setting recommendations, and it's not uncommon that I get a phone call and said, patient is not tolerating, it's too much, can I go lower? And I think that's really the value of the respiratory therapist working with the patient and find out where to start, and certainly we can go up as the tolerance to treatment increases. And we are fortunate to have the auto-titrating devices, and those include the AVAPs and for Philips Respironics and Auto VPAP, ResMed, and then last but not least, Trilogy, the Philips Respironics in the AVAP mode. And what those machines are able to do is to titrate the level of support based on a certain depth of the breath that we need for the patient. So it does make sense. As the weakness gets worse, the pressure requirement will gonna go up. So instead of coming back every 3 months and say, it's not enough, we look at the data card chip, the chip data and say, you're not where we we should be. Let's bump you up. The machine will going to do it automatically, and will, differ from night to night based on the depth of your sleep, the position, if you are on your back or on the side. Those are just some of the interfaces. I apologize if anybody else is here that I didn't include the picture. I just took it from a review article. And I think what I wanted to emphasize, there are multiple interfaces, whether it's a full face mask, a nose mask, or the nasal pillows, and how the headgear would gonna look like. It's really what fits the patient. So I think it's really working with you and see, how can we make it comfortable and easier for you. This is the main point. How do you get set up? And I'm not going to talk about, being set up in a hospital, because that's not the real, it's not the more common environment where we set the patients up. And I work at the VA, so we may have a slightly different process, but I will make it generic. What do we do whether we set the patients up in the outpatient clinic or at the home setting? And what we do, we give directions, what is the mode that we would like the patient to be set, and the pressure settings. And I could not emphasize more the value of a trained, experienced respiratory therapist. I am as good as they are. I can give the best settings, and if they don't work for you, it does not matter. So working with you and working with the families of how to make this work for you is priceless. We start low and we increase the pressures as needed, and then we want to make sure that it's a good mask that would not put too much pressure on the face or the head. How to monitor once the patients are on the machine? Well, if you look at the Medicare guidelines that say, well, if you use it more than 4 hours, that's good compliance. Well, it's good compliance, and these are data that are coming for patients with sleep apnea. We are talking about a different entity. So 6 hours, what seems to be a good compliance, and really for a lot of the patients, it's not going to be 555 versus 605. You would see the patients who are not able to tolerate, they are the ones who have been using for an hour or so. And then the patients who are able to use it, they're going to use it for 8 to 9 hours. And as the disease progresses, they're going to use it during the day. And as the disease progresses even more, they will use it 18, 20, even around the clock. How do we make PAP adjustments? It's really based on how the patients feel. And we're not gonna, there's very little data. Some data suggest, look at your blood gas. But I think a lot of it is based on how the patients feel with the pressure they are on. And a lot of the adjustments were gonna be upfront, and at least historically, it seems that once they are comfortable on the machine, those settings will be continued. The machines are getting, they have the cards, the little chips that provide us great data. And we look at those numbers and we make adjustments once we interpret this data. How to augment cough? As I mentioned before, cough is pretty complex. And I'm just going to review with you what do we need in order to be able to cough. So first, we need to take a big breath, as big as we can. So the diaphragm contracts, goes down, and this chest wall goes up, and we take this big breath. And then the vocal cords have to shut close so the air is not escaping. And then we need to force the air out, and that's where we squeeze the belly muscle and the rib muscle to force that air out once the vocal cord relax. So you could see how complex this process is. So if the patients have any kind of involvement of the breathing muscle, whether it's inspiratory, expiratory, or the neck muscles, the cough are going to be non-existent. There are different ways to augment cough. I'm going to start with the mechanical insufflator, exsufflator, or the cough assist device. Again, I emphasize the importance of working with a trained, experienced respiratory therapist. They will start at lower pressure and go up. There are some goals, and there is reality, so I think it's anywhere in between of, making sure that's working for you and the patients tolerate. And the indications are pretty clear. Patients who cannot cough up and have had a lot of respiratory infections. What are the challenges? The air, what the machine does, it pushes big pressure, so that would, expand the lungs, and then switches to negative pressure, so it sucks the air out. So if the vocal cords do not close, that air that goes in cannot be kept. So then air will gonna leak. And then the other part, if you have a floppy breathing muscles, when you apply this negative pressure, the patients will feel they are strangled because they are really gonna close on the back of their throat. They said, this is scary. This is much worse than I would rather not use that than not be able to cough. So again, working with the patients and adjusting the pressure, and I'm not going to claim that I know all their tricks, and that's where I value their experience. And then other things to help with cough. And Marlette and Ellen can talk a little bit more about it if you are interested about the breath stacking, the manual cough assist that requires training to the families and the caretakers that can help augmenting cough manually. And then if the phlegm cannot be coughed up and it's in the back of the throat, the suction machine can help. And then we have the vest chest physiotherapy. So you may have a lot of questions about it. I can tell you in my own experience, the success rate is about 50-50. The vest has been used in patients with cystic fibrosis, and it's a great way to mobilize secretions and get rid of them. But I don't think we have that level of data, positive data, in the patients with ALS. For some of them work, for some of them don't. And I think, as far as the practice parameters, the recommendations are pretty much the same, can be used. We don't have enough data to say that we're going to absolutely work for the patients with ALS. And then controlling secretions. To be honest with you, this Dr. Barkhouse does it in clinic. By the time they come to me, that this is already in place. We have different strategies, different medication, injections or radiation based on how bad the symptoms are. What about diaphragmatic pacing? And I'm sure that a lot of you have questions about it. Anybody in the audience has a diaphragmatic pacer? No. The diaphragmatic pacing was first used in patients with spinal cord injury, and has been used first time in ALS, I think in about 2005 or 2006. And the device was approved by FDA for patients with ALS in 2011. And has been approved as a humanitarian use device, which means that it's safe, but we don't know how well it's working. And I think that's the main point that I would like to make when it comes to diaphragmatic pacing. I have a couple of patients. At the VA, we do not insert those pacers. The patients that came to me came from Chicago. I can tell you that both those patients were using the non-invasive ventilation. They were at early stages, and the disease continued progressing, and at some point the pacer has not worked. What do we do when we insert the pacer? Well, you have to have a working diaphragm, and the electrodes are placed on the abdominal surface of the diaphragm, and they look where the phrenic nerve comes and inserts on the muscle. So you should be able to innervate the diaphragm. You should be able to, once you put those electrodes, the diaphragm will squeeze, otherwise it's not going to work. However, what happens throughout the time is those motor fibers that worked may continue dying, and the diaphragm may not work. The other part is the electrodes have a certain thickness, so the diaphragm has to have a certain thickness for the electrodes to be placed. So before the diaphragm pacer is placed, The referral centers, they run certain tests. They look at whether the diaphragm is moving. They look at the thickness of the diaphragm, whether with ultrasound or the CAT scan. And then there is the operation, and then the electrodes are attached to the pacer box. There are complications from the surgical procedure. Every time you have a foreign body, there is a risk of infection. And then there is some level of discomfort that the patients get used to just from activating the diaphragm. However, even with the diaphragm in place, the disease will, as I mentioned, will progress. So at some point, that may not be enough. And last but not least, mechanical ventilation. When should mechanical ventilation be considered? And again, I can't emphasize enough about the importance of early discussions. So it's having that discussion not in time of crisis. When something goes bad, there are a lot of emotion, there is not a lot of times to think. And I don't think it's a right or wrong answer for anything. It's just what the patients want, and we just need to know about it and think it through and see how we are best prepared and positioned. When that time comes, we will do what our patients want us to do. And what to consider that? Well, as the disease progresses and the numbers get worse, and we look at the magic numbers of less than 50%, and the patient don't tolerate the BiPAP or the non-invasive ventilation, or if they are on non-invasive ventilation, it's not enough anymore. Probably a lot of you are already using the mouth ventilation or sip and puff ventilation. It's provided through the Trilogy mechanical ventilators. Our vendors are here, and I'm sure they can talk more about it. But it's really providing this big breath. It's a mouth ventilation, so for the patients who have symptoms despite using the machine 16, 17, 18, 20 hours, or they need a break. They need a break from having that mask on the face. That mouth ventilation provides them big relief. And then when everything fails, if the mechanical ventilation is still an option, we can talk about the tracheostomy and the mechanical ventilation. It's not very common in the United States. It's probably about less than 5%. But there are some other facts that you should know about it. As once the patients are on mechanical ventilation, the disease progresses. So there is limited survival even patients are going mechanical ventilation. The respiratory infections are still the most common cause of death. The ability of them to communicate to us and the quality of life will gonna decrease over time. And then it is pretty challenging on the caregivers. They need a lot of support and they are happy to do it, but we need to make sure that we can help them. And we need to make sure that they have an emergency plan in place, if the power goes out, the machine goes down. Those kind of things we need to be proactive in thinking about. And then at the end of the day, as I mentioned probably 5 times so far, is what do you want? And when it's extremely important for us to know when it's not enough, it's enough, even whatever that circumstance may be, and the patient no longer would want that intervention. What else should we consider? Good care, that's what I would call it. Prevent infections, good nutrition, treat infections early, so pneumovax, make sure that, if the patients have a lot of problems swallowing and they cannot maintain their caloric needs, a G-tube and tube feeding to make sure that they don't lose additional muscle mass just because they are malnourished. And then palliative care, and by palliative care I mean symptom control. There's a lot of confusion, or even for our trainees, between palliative care and hospice care. So when you hear palliative care, you automatically think that's it, 6 months, that's what I'm here for, and it's not. It's how can we control the symptoms. I think when we train as doctors, we think that we can cure it all, and I am also an ICU doctor, and that's what I thought. The patients come to the ICU, I'm going to save them all. But you realize the big part of what we do is control symptoms. And if we don't control symptoms, we are not good doctors. I think it's my job to do that. So we should have those discussions, and Dr. Barkhouse is doing a great job. So by the time they come to me, those discussions are in place already. So it's really about for me to see where the patients are any additional questions, and unfortunately, we are driven by RVUs and how to see more patients. But this is the kind of discussion that we're going to make a difference for our patients. So in summary, early intervention in respiratory care improve quality of life and may improve your survival. If the patients decide to go on invasive ventilation, I think we should discuss it all. We should talk about all the aspect that's related to the tube in the throat, to the ventilator, and to the patient. And palliative care, which include access to symptom control, should be provided up front. I don't want to go over all this flowchart, but it pretty much summarizes what I just talked to you about. And this is the algorithm that we go through as we take care of patients with breathing problems who come to the clinic. As I mentioned, you start with the evaluation, the symptoms, when you consider what intervention, and this is the practice parameter update that was published by our neurology colleagues in 2009. And how do we treat our veterans with ALS at Blocky VA? I am blessed to be part of an extraordinary team, and it includes a neurologist, so Dr. Barkhouse is the lead physician, a nurse, a respiratory therapist, a physical therapist, a dietitian, a social worker. Their clinic is once on a Tuesday. My clinic is on Monday, so I try to go to clinic to that particular clinic. So I'll do my best. I can't promise that it happens every time, but I will try to avoid an extra trip to the hospital. They get a spirometry every visit, and the patients, once the consult is placed, I try to see the patient within a week, and we are blessed not to deal with Medicare, and we think that the patient needs treatment. We are able to provide the non-invasive ventilation in less than a week, but that's probably not the case for a lot of other patients. And that is the end of my talk. I thank you for your attention.
We decided to do something a little different for the second portion. So it's not that we ignored the ability to ask questions. We're going to have a panel here so that you can ask some questions. We're going to do something more in an interview type way initially, and then we'll open it up to general questions. I'd like to introduce our two presenters here that have joined us. First of all, Marlette Shepker. Marlette is the respiratory therapist for our ALS clinic at Froedtert Hospital. She's been a respiratory therapist for 23 years, graduating from the Mayo Clinic in Minnesota. And Marlette has been employed with Froedtert Hospital for the last 8 years, working in the pulmonary diagnostic lab and ALS clinic. So welcome, Marlette. Then we have Ellen Newman. Ellen is a registered respiratory therapist with the Milwaukee VA Medical Center. She has been with the VA since 2003. Ellen holds a Bachelor of Science degree in elementary education from the University of Wisconsin-La Crosse and received her associate's degree in respiratory therapy in '97. Ellen has been a member of the VA Medical Center clinic team since 2010. So welcome, Ellen. So I have to put my interviewer hat on. So we'll see how this goes. But first of all, I think when we were talking and we were planning this presentation, we talked a little bit about your role, because I think as Dr. Anton said, you are a team. Right? All of you are a team. So could you describe your role in the clinic?
Sure. I guess I work obviously with the other clinic team members. We work closely with each other. And then I'm also work as the liaison between the clinic patient, the pulmonary physician and Dr. Barkhouse to help facilitate when you need to see a pulmonary doctor and when you need equipment.
And mine is basically the same. When patients are new to our clinic, and maybe this is with your clinic too, we give them a pamphlet, and it has all of our names in here and pictures, all the disciplines, and the nurse and Dr. Barkhouse. And it just tells them a little synopsis of what we do and our phone numbers, which is very important, so then they can get a hold of us anytime. So that's how we start out when they're new patients. And then when I see the patients, we get their weight, and then my job is to do the spirometry with the patients. And we typically do three blows and then stop there, just because it is pretty grueling for them. And then I just made this up myself, but I use a checkoff sheet. Anytime I call the patient, I'll write on here, or any notes that I need to know. And then when they come in, I'll have the results from the last time they were in, so that if they weighed 150 pounds today, what did I weigh 3 months ago? I can tell them that. And I also ask them about their shortness of breath and how they're sleeping, and then just go over the equipment that they're using with us and ask them how it's going, maybe talk about different things they may need, and also if there are any supplies they need. I have the ability, I don't know if you do, but to run down in some departments and grab some supplies if they're short on them. Not always, but so just to try to make them happy and get them everything they need. And that's about it.
Thanks. Well, this is a strange question, but I think we've heard it from the care services standpoint, and I've had some people tell me they dread the respiratory therapist the most at clinic, and you can understand in some ways, but what would you tell somebody that is feeling that way, that's very nervous and may avoid clinic just because?
Nobody likes to have that pulmonary test done because it gives us a number. And as we see that number go down, that makes people very anxious. But for us, I look at it a different way. It's not just the number. That's not totally why I'm there. I'm there to help with any symptoms that you're having. I'm more concerned about that. Yes, we need that number to get you what you need when you need it, but I'm concerned about symptoms because there's other things that other testing that we can do besides that forced vital capacity to get you that equipment sooner than later. So, and I usually come in first, get the hard part over, and then we're done.
And I'm the same way. I see them first, and I know what she's saying about the anxiety over you're getting your forced vital capacity number. But just know, too, and I know you touched on that, too, there are some patients, when you breathe out, you're supposed to keep everything nice and open for the spirometry, like that. But there are patients who close their glottis, and then when they blow out, it's ooh. So their numbers are going to be low, and it's really not a true number for them. Or some patients can't put the mouthpiece in their mouth, so we'll put a lip seal. I'll hold a lip seal over their mouth. And I'm sure there's going to be leaking, and that's also a false number too. So, I mean, they are a guideline, I guess you would say, but they're not a perfect number. I don't know.
I certainly echo the comments, and just my last clinic, as I mentioned, I have clinic on Monday afternoon. I had this family, the patient is a veteran, and his wife was with him, and his forced vital capacity now was 18%. So she said, I'm ready for hospice. And the patient said, well, I feel about the same. Nothing is different, but, I'm told that, I'm going to die. So a lot of, I think, as the number goes down, people want to know what was going to happen. And I think that's the main message that we want to get across is it's not the number. We look at you, and we're going to help you. And, I ran a couple of tests, even, the oxygen level at night, the blood gas, to just reassure the patient that that number really doesn't mean anything. It was just a poor test. However, you get the number, and nobody can fight numbers, right? Everything else is subjective in life, but we can't argue with numbers. So once you get the number, it's like, oh my God, what is coming? Is it 2 months? Is it 6 months? Is it 2 weeks? And I think that's where we need to help you and say, explain what happened and guide you through your journey. So don't get caught up on numbers. We will put that in the context of taking care of you and what do we have to help you feel better.
Thank you. I think another discussion we had when we were talking about this was it continually came up as to when and why should a person who has been diagnosed start seeing a pulmonologist. I think because not everyone is recommended at the same time, especially if they're not in an ALS clinic. And Marlette, you mentioned a few things on that.
I'm finding out that having you see a pulmonary physician early is turning out to be a better idea because of Medicare and the time that it takes to get the equipment. It can be a month to 2 months. So I'm asking people to see a pulmonary physician, even though they may not be having symptoms or their forced vital capacity is still on the higher end. I'd like to get started with a relationship with a pulmonary doctor so that as things progress, you already have a pulmonary physician in place, and then I can act as the liaison when you're having more troubles with that pulmonary physician to start the process of getting the equipment.
So you're saying that no matter if it's a pulmonary physician within the any pulmonary physician
I'll work
in
with
their
any
area.
pulmonary physician. I work with Dr. Potts in the Green Bay area. Him and I are on good terms with each other. And if you are working with a pulmonary physician who hasn't worked with an ALS patient, by all means, give them my name. I give out my email, my phone number. I'd be more than happy to help that pulmonary physician get what they need to get this process moving. So I've worked a lot of years with Medicare and this process, and it's a challenge. So.
Well, working at the VA, it's quite different because I know if a patient, we don't get them in to see a pulmonologist right away. It's more if they start having symptoms with shortness of breath, their forced vital capacity starts going down, maybe some symptoms of retaining carbon dioxide, of headaches, morning headaches, weakness, confusion. So times like that, then I would say, you probably should be seen by a pulmonologist, but I know they can get in to see you pretty quick. Or if they say they're ready to go on an AVAPS, that's not something I can order, so they would need to be seen by Dr. Anton first. So there are some things that only she can order and would really need to see the patient first to make the right decision.
And I think that's where the team approach comes into play. It really, the VA has different challenges, but that ordering PAP therapy is not one of them. I can tell you that from the time that Dr. Barkhouse is and the ALS team sees the patient in clinic, if there is something that needs to happen, less than 2 weeks, I get a phone call from Dr. Barkhouse, and, he tells me, I get an idea about how urgent it is. And it really depends. If everything seems pretty straightforward and the patients do need therapy, I can order the therapy even before coming to clinic. Those patients would come to us. I have a very good respiratory therapist that will work with the patient and tell me what works or not, so we're not going to delay the process. For some patients that they have other symptoms that I know that, they may think that the PAP therapy is the solution to all the problems, but really is not, then I'm not going to prescribe therapy before they come to see me. So we have different processes, but it's pretty streamlined, and we communicate very easily, and the therapy is provided, as I said. So, and they really, if you think, there's really not a lot of evidence that if you don't have symptoms, starting PAP therapy up front will gonna help you. There are actually, some concerns that if there is some element of dysfunction associated with disuse of the muscles, if you don't use them, maybe that's not a good idea. So, it's good to be proactive, but being too proactive, it may not be too good. So we are waiting for the symptoms, and it's just because we don't have that 2 months challenge ahead of time. Once the patient is identified, sent to us, then the process is pretty fast.
Sorry. I was just going to say the reason that it takes so long on my end is that the patient does have to see a pulmonologist. The testing and the order for the AVAPS or PAP machine has to all be done within a 30-day time period per Medicare. And so sometimes getting that coordinated is difficult too. So.
That was actually my question.
Yeah.
So, having said that, what would you recommend people could do to help, to be the squeaky wheel? What could they do to be proactive with the companies if they're trying to stay on top of it personally?
What's happening here in Milwaukee and not in all areas is the home care companies, we're only allowed to go to certain home care companies that have the Medicare competitive bid. And these companies are not keeping their equipment on the shelves. That's what's taking so long. So from a patient advocate perspective, you need to call that home care company. You need to be on them, calling them, is the equipment in? You got an order from Freighter. Where's that order? Where are we in the process? Even though I'm doing a lot of that on the back end, it really helps if you guys can do it from your end also. We have to start putting pressures on these companies because they're not keeping up with our demand.
Well, thanks. Sometimes it's hard to feel with all the other challenges that they have to do this too, but
Right.
It's important.
Right.
Does anybody, I think at this point, we've asked quite a few questions. Does anybody have some questions in the audience that they would like to ask? We have some microphones. Wait for the microphone.
This question perhaps is for Dr. Anton, I'm not sure. Could you speak a little more to the concern about how sleep apnea affects or compromises the health of an ALS patient? And in fact, is it true that apnea causes the motor neurons in the brain to die due to lack of oxygen, and does that shorten the lifespan?
So there is, so I think we are talking about, two different diseases, and actually, sleep apnea by itself will not necessarily make the ALS worse or the cells die faster. The patients with ALS do have central sleep apnea, where the drive to breathe is not there. That being said, and I think that's where an area where we are gathering a lot of information, obstructive sleep apnea, where you have low oxygen levels, we know that's actually causing oxidative stress and injury to the brain. So, whereas we don't have strict evidence, it makes sense that, low oxygen levels and those frequent interruption of sleep at night will not going to help. What we do, the main treatment for obstructive sleep apnea, it's CPAP. And CPAP, it's a straight pressure, and it's really that expiratory pressure that keeps the back of the throat open and prevents it from closing. When we talk about support in patients with ALS, we talk about two levels, an inspiratory level and an expiratory level. So if the patients do not have obstructive sleep apnea, that expiratory pressure is kept to minimum because it's very hard when you have weak muscles to breathe against high pressure. However, if the patient have obstructive sleep apnea, then that pressure needs to be kept higher so it maintains the back of the throat open. And then you add extra pressure in top of that expiratory pressure to boost the inspiration, to be able to breathe better and deeper. So, in other words, having obstructive sleep apnea, those are two different disease entities. It's not that obstructive sleep apnea is it's extremely common. It's more common than asthma. And you could see that ALS, it's a rare disease, so it's not that having obstructive sleep apnea predisposes to ALS. However, there are a lot of data suggesting there is brain damage from obstructive sleep apnea and that lack of oxygen, and one can worry that in the context of ALS that cannot be helpful. So again, you would need different pressure settings to be able to treat the obstructive sleep apnea and the ALS at the same time. So,
Thank you. Does anybody else have questions? Okay, I think I have one more question. I know Dr. Anton has another presentation that she has to leave for, but so we have to say goodbye. But I just want to thank you again for being here and just sharing all that valuable information.
Thank you.
Thanks.
Thank you.
What I'd like to ask, I know Dr. Anton brought it up, and I know some people have had some questions about breath stacking.
Mm-hmm.
Could you guys talk about that so people understand things that they can do just without any equipment?
Breath stacking. Maybe I'll have to stand. I know you know this. Go ahead. There's actually, if you type that in, I Googled it because I know you had mentioned you found a good website, and you can see a YouTube of this. So it's actually very interesting. Some show it using an ambu bag, a rescue bag, but you can do it just on your own. What you do, correct me. You take a deep breath in, put your hand on your abdomen, take a deep breath in, hold it, take another deep breath in until you can't breathe in anymore, and then when you exhale, you keep your lips nice and tight so that you're breathing against a resistance. And what that does is it expands your lungs, recruits your airways, prevent atelectasis, and hopefully prevent pneumonia or an infection that may be coming in. I don't know if you want to add something to that, Marla?
No, that was good.
Okay. Yeah. So that's nice because you don't need equipment for it. But.
And that's really helpful because I think what we were talking about too is some other home remedies for things like, like possibly humidification or secretions. Do you have anything to add to people that maybe have some really thick secretions or, just an overabundance and maybe some things they can use outside of medication?
Well, thick secretions, Michelle, the dietitian, usually she'll have some good suggestions. I always say stay away from dairy, but I guess that's not the case. Water intake is huge. And I hear a lot of people using Mucinex. I guess if it works, then use it. Yeah, she's there.
Michelle, do you have anything to add? Okay, and I think, again, if you have a question, please feel free to raise your hand. Otherwise, I think we have one last question for you. Oh, you do. Wait.
Just a couple extra home remedies, and you guys tell me if this is wrong, because I don't want to mislead anybody. But one woman told me that pineapple juice and green olives, like to suck on green olives, helps with secretions, and pineapple juice, like the acid in it, would help.
I haven't heard of that. That's
So,
a new one.
If you try it and something happens, don't. No, I mean, doesn't it make sense, the acid? So you never heard of those things? Any kind of home remedies?
I've heard spicy food sometimes can help. I've read stuff in literature, but again, that can also cause reflux, so that could be
A bad
problem. Yeah. And to avoid a lot of caffeine, right?
Yeah.
You don't want to dry anything up.
Yeah.
Okay. Thanks. Thanks, Mary.
You never know.
Um,
Whatever works. Right?
I think one of the things that we were talking about is, many times all this extra equipment, people can feel really isolated and contained, and maybe they can't. I'm going to be starting on this BiPAP. I'm in a wheelchair. Can people still travel? Can they still get out? I mean, the one thing that we want to make sure is that you're living with ALS. So could you comment on that?
Sure. Travel. You can go on airplanes. You can take your BiPAP, AVAPs as a carry-on. All you need is a quick little letter from your physician saying it's okay. And there's also external batteries. You can go camping. And there is car adapters for your car. You can be riding in the car and be on your AVAPs. So everything's portable. And some of our machines have internal and external batteries also. So.
Yeah, if you use the Sip and Puff, and that, again, is just for daytime shortness of breath. And you can hook it right up to your wheelchair and take a sip, and it gives you a nice big breath. And that has an internal 3-hour and an external 3-hour battery. The one we use anyway. I don't. Yeah. And I know a lady goes. I think her flight's 4 hours, and she just takes it right on the plane with her, so she's able to live with that. And then I don't know what suction. The suction we use. There is an external battery. I think it lasts, patients say maybe a couple days at the most. Depends how much you use it.
Yes.
So
That's true.
the suction, you can bring that with you too.
Yeah, most everything can be traveled with.
Mm-hmm.
So.
Great. Well, to close, again, I'm going to, one last call for questions in case anybody has any questions on anything that was asked. But I'd like to just close by asking you if you had one recommendation, just ask each of you, one recommendation to everyone here or to somebody that is just starting out with the challenges of ALS, what would you say?
Don't be afraid to ask questions. That's what we're here for. If you see something on the internet that you have a question about, feel free to ask me. I'll try to help you come up with a solution or and help you get to the right person. Don't be afraid to ask. And I'm always available for the hard questions. It's not always easy to talk about the respiratory part, but that's what I'm here for.
Yeah, I kind of feel the same way. Just, I know that the clinics, we're so rushed. When you get your spirometry and you can hear all the people out in the hall waiting to come see you. But that's all right. Ask, and call. If it's too busy, you can always just call. And when we talk about different equipment, I know you're probably so sick of getting more and more equipment in the house. So I can always refer you to a YouTube, and any of those things that really help, just to watch and see what the people are doing. And then it's not as scary. And then you see they won't maybe take up quite as much room. And it might help guide you a little bit better.
Thanks. And thanks to both of you. I guess this will wrap it up, but thank you,
Okay.
Marlette and Ellen.
Thank you.
This really was a great presentation. And they do mean it when they say get a hold of them, because they will be there to answer your questions. They're great. Well, that actually completes our symposium for this year. Again, it's always amazing when that's over, but I'd like to thank all of our presenters today. We had great information, and I know each and every one of them will be available for questions. I know Dr. Svensson is going to be very open. I'll be getting in touch with him about getting a copy of his slides as well as all the presenters, including Melinda. So we will make that available. We also, if you had, well, as you noticed, Steve is back there, and we're getting this video. He's going to be editing it, if I can talk, within the next 2 weeks. And so we're hoping to have that up next month, later on next month. We do have a YouTube site, and we'll have it embedded in our website. And there will be a DVD for those of you that don't use a computer. So we'll send an email blast out to everybody and let you know about that. First, I have to thank, too, Dr. Barkhouse for once again being basically being the catalyst for this symposium and just doing all the work he does to help me put this together with my team. And we wouldn't be able to do it without him, so thank you. And I just want to thank all the partners from all over Wisconsin that came, and it's wonderful to be able to be here, and you have to stay for a picture after, okay? And thank you to all the exhibitors. I know they're basically gone, and I wasn't, except for our wonderful respiratory exhibitors. We couldn't do this. This is such valuable information, and they support us year after year after year, so we're really thankful to them. And thank you to the Sheraton. They always do an outstanding job helping us and just going without a hitch, so we're really thankful to them. And thank you to all the volunteers today. We can't put something like this on without them, so that makes all the difference in the world. Just a reminder, we really, really, really listen to you. So those red forms on the center of your table, please fill those out. We collect those, we study those, we form the next program according to those. So please take a moment and fill those out. And you can leave them on the table. Otherwise, there will be people at the doorway to collect those for you. And then if you haven't already, please turn in your bingo card for your swag bag, I was told. So that's your prize, so feel free to make sure that you do that before you leave. And ultimately, we hope that you will, any questions that you have from today, you will know that you can come to us and ask questions. Our chapter exists for you. We're here to do whatever we can. Our mission is to serve all chapter families and patients in Wisconsin. So we thank you for being here today, and drive safely. And for all the mothers, have a wonderful Mother's Day next weekend. Thank you very much.